Good morning, everyone, and welcome to our Secure Care in Focus International Insights to Inform Queensland Practice webinar. I hope you had a lovely kind of conclusion to your year, and this is the final webinar that PCare will be hosting for 2025. So it is lovely to have you join us one last time this year, and kind of, as I'll say at the beginning and at the end, we wish you, your teams, and everyone who supported children and families this year a wonderful break over the holiday season. I would like to start by acknowledging the traditional custodians on whose lands we are joining from today and pay my respect to elders past, present and emerging. For us, that's the Yagara and Turrbal people on Meanjin, but I also want to acknowledge and extend my acknowledgement and respect to the traditional owners on whose lands you are joining from today. We are delighted to have more than 200 delegates registered to join us for today's webinar from across the country, with a great representation from Queensland, but from every state and territory represented, and a few early risers who will be joining us internationally as well. So it's wonderful to have such an engaged audience for what's going to be a really important conversation. Now, just a little bit of housekeeping before we get started. So we are recording this session and we will be sharing a recording of the keynote as well as the panel session. We've also activated the Q&A function. So we invite you to provide any questions you may have. And while we have a tight agenda, we'll aim to answer a few of the Q&A questions and also try and group some themes and respond to those themes as we send out our post-event summaries. We know it's a really important area of conversation. We know it's a really important, engaging session, but we want to make sure that we kind of do justice and honor your time and also be able to share out some useful insights and evidence. So taking you through the day, we're going to open with a fantastic keynote from Kate Crowe. I'll introduce Kate in a moment. She's going to take us through some of the international insights from her expertise and academic work, and then we're going to move into a panel. I'll introduce the panelists to you as we come to that, but we're delighted to be joined by the Principal Commissioner and Chief Executive of the Queensland Family and Child Commission, Mr. Luke Twyford, as well as Ms. Jo Rofe, who is the Executive Manager of Service Delivery for IFYS and herself has done a lot of work and kind of thinking in this space, which is absolutely fantastic. It's going to be great to have oversight, an academic lens and a practice lens applied to a really important part of the conversation about Queensland's care continuum. So I want to set some initial framing, particularly what PCare's interest is in secure care. And secure care has been a long-standing topic of conversation. It's been more than a decade since some seminal literature was published by PCare around how we may consider approaches to secure care in Queensland. We've had inquiries that have looked into it. We've had commitments from governments, and we as a peak body are really keen to create an opportunity and a space to look at the evidence, the literature, the insights that should inform how we proceed as a service system, to create a space to hold a conversation, which is really important, but also to kind of bring you the best contemporary evidence to support you in your work. So thank you for being a part of this, a really important conversation. Now, secure care sits at the intersection of safety, rights, and therapeutic responses, and also the realities of a system under immense pressure. From PCare's perspective today is about bringing the evidence and the practice insights into sharper focus. So what we know, what we're learning, and what this means from a policy, commissioning, and frontline practice perspective, that's what we're all about today. Now, I want to just put in a quick note that this is going to be a space for thoughtful and respectful discussion. So we're going to be talking about children and young people who have complex needs. Some of this content may be a little bit challenging. So please take care of yourself, step away if you need to, and reach out for support where appropriate. This is and can be a really important, but also at times a challenging conversation. I also want to acknowledge any people who are joining us today with a lived experience. So I'm delighted to introduce Kate Crowe. So Kate holds a long-standing commitment to improving interventions and safeguards for children and young people experiencing serious vulnerability. For the past 20 years, Kate has worked in the Commonwealth and state government leading reforms in youth justice, alternative care and secure care. Awarded a 2022 Churchill Fellowship, Kate studied effective alternatives to secure care for high-risk children and young people in Scotland, the Netherlands, Canada and Hawaii. In 2023, Kate was awarded a Creswick Fellowship to investigate the position and design of secure care when jurisdictions raised the minimum age of criminal responsibility in Scotland, Finland and Iceland. She is an honorary fellow of the University of Melbourne, has published extensively on including secure care and alternatives. And she's a member of the group of international researchers in adolescent forensic research, which is the abbreviation GIRAFFE, and co-leads the baby giraffe subgroup on alternatives to secure care. So welcome, Kate. We're delighted to have you join us today for your keynote. Through the power of technology, we're now going to seamlessly transition across to your slides and get things underway with our keynote for today.
Thanks, Tom. I appreciate including me in the conversation, a really important conversation Queensland is having at the moment on secure care. So I am going to, as Tom said, seamlessly transition to my presentation. So hopefully you can see this. I think it might need a couple seconds to kick in. Yep, great. So as Tom mentioned, I am representing, my affiliation at the moment is the University of Melbourne as an honorary fellow. So I'm not representing either Commonwealth or state governments here today, but I would also like to start by acknowledging the lands in which I am presenting. So the lands of the Wurundjeri people of the Kulin Nation, and I would like to pay my respects to elders past, present and emerging. I am going to give a very quick overview, as I said, seamless transition. Hopefully you can see this next slide with the structure. Just double check. Yep, brilliant. So today's structure will give you a high-level overview of secure care, providing some definitions to guide the discussion that we're having today, and give a high-level overview of secure care in Australia, noting, I think, the interest today is really looking at sort of international examples, so international precedents when it comes to secure care and alternatives to secure care, but also give the audience today a little bit of an overview of what the research sort of indicates in regards to how we should design secure care. So secure care, I'm defining, well, I think it's important to note that there is actually no internationally recognised definition of secure care. So myself and others within the Giraffe Research Group are really trying to come up with a definition of secure care. I'm focusing on the deprivation of liberty deprivation of liberty of children within the child protection system, the welfare sector, when they are at significant risk of harm to themselves or others. Now, we could spend almost the whole 45 minutes today talking about the definition of secure care, but I won't put you through that, and I'll just focus on a couple of the very important elements. So we're talking about children. So there is often a maximum age of 18 years when it comes to children admitted to secure care. There often isn't a minimum age, but it's generally around 10 to 12, so the age group of 10 to 12, and they are children that are generally involved in the child protection system, so they have child protection involvement. And a key point to the definition is that they are at significant risk of harm to themselves and or others. Now, Australia, due to our bifurcated welfare and justice system, so the forked approach, I guess, to managing children's complex behaviours, we have separated the child protection system and the youth justice system, and generally we have secure care looking up children and young people within the welfare sector, so the child protection sector, when they're at risk to themselves, and then we have young people in the justice sector that are generally detained when they're at risk to others. But we have seen in recent years, for example, the Northern Territory, ACT, when we raise the age of criminal responsibility, we have a combining of those two client groups. So we have children that are either at risk to themselves and or others. So when I'm talking about the deprivation of liberty, so I'm using the UN definition of the deprivation of liberty when a human being is confined to a narrowly bounded location and they cannot leave at their own will. Within secure care, there is always restrictive measures, in my experience, in secure care facilities. My definition for restrictive measures, I think, is a good one. So it's acknowledging that there's both legally authorised and socially and professionally sanctioned coercive measures. Now, within the secure care space, they are generally pretty consistent. So within Australia and internationally, we have seclusion rooms, often in secure care facilities, almost always. We have clothed and unclothed searches. We have use of force. We have removal of personal devices such as mobile phones when young people are admitted to secure care. And when we're discussing secure care today, in terms of alternatives to secure care, they're really referring to community-based diversions and therapeutic interventions designed to address the needs of children that are admitted to an involuntary containment in a locked facility. So those alternatives, I'll talk a little bit more later on and what they can look like. But generally, when I'm referring to alternatives to secure care, I'm referring to non-residential care interventions because the United Nations define residential care as a form of deprivation of liberty. So in a nutshell, Australia is quite hard to provide an overview of secure care in a nutshell. But with the introduction of secure care in Queensland, we're going to have secure care in all states and territories except for Tasmania and South Australia. What secure looks like in all of these states and territories within Australia is quite different. We have models that might be a maximum of 21 days, and we have such as Victoria and WA, or we might have long-term interventions like that's what's provided in the New South Wales, which can be a year or two with potential containment. Secure care within Australia, with the introduction of the exception of the ACT, which has raised the age recently, is targeting the child protection cohort. So it is generally children that are residing in residential care that are going into our secure care facilities. So ACT, with the increasing age of criminal responsibility, is really introducing a community-based client into the secure care cohort, which is new for Australia. Secure care is delivered generally, ACT is the exception recently, by government, and that's more consistent. The ACT is more consistent internationally, where they are generally delivered by the not-for-profit sector. I'll talk about that a little bit more later. We have legislation for our secure care facilities in Australia in all states and territories except for New South Wales and the Northern Territory. So it's not something that can be taken for granted that secure care legislation exists in Australia, in a state and territory that has facilities. The New South Wales is a bit of an exception because they go to the Supreme Court for all admissions. And I should also mention, when we are talking about definitions of secure care, there are two forms of secure care facilities. So secure care facilities, in that you might have a particular facilities. For example, New South Wales have Sherwood House, and Victoria have secure welfare services, which are units. And then we have another form of secure care, which is referred to as separate care, which is the locking up of a residential care facility. So it's not a designated secure care facility. It might not be gazetted as such, but it's just community-based residential care facilities that is having its doors locked and other restrictive practices as part of its practice. There is the use of administrative detention in Australia. So this is when we authorise admissions to secure care without going through the judicial system. So what does that look like in practice? That's generally the child protection management system or level that will authorise secure care admissions. This is consistent in many ways internationally, and there are these differences that I've pointed out. So the differences are that it's often delivered by the not-for-profit sector internationally. Australia has single-sex facilities, which is uncommon internationally. They are generally a gender-neutral intervention. Internationally, it's almost a given that legal orders will be required for admissions, so they generally don't utilise administrative detention, which also, when you have a secure care order in place, it means that generally young people have access as part of that process to legal representation, which they don't always in Australia. Generally, the practice of secure care is a bit more transparent overseas. For example, we don't have, as a whole in Australia, admissions data that's publicly available. For example, it's not part of the AIHW Child Protection Report. But what is consistent is that we're responding to the same client group generally. Internationally, they are residential care clients, so within the child protection system. They are very complex children and young people, so there's often self-harming, sexual exploitation, AOD, disability, and mental health issues. So the cohort does seem to be the same, except with the exception internationally, there seems to be a bit more of a targeting or responding to criminal exploitation, which we don't seem to so much in Australia. Internationally, there are, and in Australia, there's significant variations in the models. There's generally the absence of outcomes-based research, and the restrictive practices are the same internationally that I've talked about. And there's a consistent view that secure care is filling the gap within the service delivery system, particularly the mental health sector. So when we're talking about the research, there's an absolute lack of research within the secure care space that can really clearly define how we should be responding to this cohort in terms of secure care intervention. The research suggests that there's a lack of outcomes in this space, but also Nuffield, so this is a UK research institution, have gone as far as to say the long-term place in the long term, a placement in secure care is unable to fundamentally improve a child's outcomes. So I think this is really worth bearing in mind, that secure care as an intervention isn't something that can be really utilised to improve a young child's outcomes, but might be more of it should be viewed in terms of its design as more of a crisis intervention in terms of protection in a point of time, as opposed to fundamentally improving a child's outcomes. That it's the alternatives and the service system that's around the secure care intervention that really can make those improvements. But that secure care can really be improved, and hopefully this will show a shift in the improvement in outcomes relating to secure care interventions if we can really improve the coordinated support, that multidisciplinary support, and provide better transitional placements from secure care. So as I mentioned, internationally, we are talking about the same cohort. So they have been residing in residential care at the time of admission. And I'll show you some data that was released for my Churchill report in Victoria, which really speaks to the extent residential care is the feeder into secure care facilities. But it's not just the children that are in residential care, it's that pointy end of the residential cohort that have experienced multiple placements in residential care. There's the overrepresentation of our First Nations children and young people, and this is maybe not to the degree there's not a lot of research in this space, but it's not to the degree potentially of youth justice, but it's getting pretty close. The children have multiple and complex needs that require really quite intensive and specialist interventions across disability, education, health, and care. But also the cohort that secure care is responding to, and this is a sort of, I guess, an assumption or a known fact within the sector, but we haven't had a lot of research to back it up, is that secure care is accommodating children with diagnosed mental health conditions that aren't meeting the threshold for an involuntary admission. So again, the Nuffield Institute in the UK have come up with 3 quite nice cohorts around the secure care cohort. So the disability cohort, the complex needs from ongoing trauma cohort, and also the sexual exploitation cohort, though I do think it needs to be recognised that the disability cohort and the sexual exploitation cohort are also the complex needs cohort. So this is the data from Victoria that I was talking about that sort of indicates that 90%, well, it does indicate that 90% of the admissions that are going into secure care in Victoria at this time were from residential care. I should note that the picture there is not of secure care in Victoria, but of secure care, the Kath French Centre in WA, because there's no publicly available images of the secure care in Victoria. So about 2/3 of the admissions for this period of time were female. So we see a little bit of a flip from the youth justice system, where we see a lot more young men than young women, which goes to, there's a lot of historical literature about secure care responding to status offending for women. So particularly controlling, I guess, and responding to female sexuality. I think the literature has evolved, but that's, I guess, historically, potentially what researchers thought was the intent of secure care. Victoria admit approximately 300 admissions annually, so that's not unique clients. So that probably equates to about 80 or 90 unique clients, which speaks to the repeated admissions that we often see in secure care. So the same client group that are being repeatedly admitted. Victoria, that also speaks to Victoria's crisis model. So it is a short-term crisis intervention, 21 days, that can be repeated for another 21 days, which sees a very short length of stay, which is shorter than your probably average length of stay internationally. So Victoria have 8 days. So this just indicates the variety of reasons young people can be admitted. And these aren't the reasons, it's the combination of factors. So they're often missing from care, substance abuse, suicidal behaviours or self-harm, mental health issues, and sexual exploitation. As I've implied, there's a lack of secure care, there's a lack of research supporting secure care efficacy. However, there are indicators of what is good practice in this space. The research at the moment is often conflicting. It's incredibly small scale, anecdotal, quantitative. But for example, the research group that I'm involved in with the giraffe are looking at doing a longer term, linking in with some studies that are being commenced on longer term outcomes for children that are admitted to secure care. And our perspective is comparing that with the outcomes of young people that have not been admitted to secure care that are using alternatives to secure care. So where we do see positive outcomes in this space is where we have locked institutions that are generally delivered by the mental health sector, so a more treatment-based models. I'll talk about treatment in the space of secure care a bit more in a second, but what the research does suggest is that secure care is ineffective in addressing risky behaviour substance abuse. So AOD is an effective response to AOD. But potentially worse than that is that it actually increases risk and can result in high rates of fatality post-admission. We also see that it is ineffective in responding to sexual exploitation and can be experienced by children and young people as quite punitive and harmful, which can have long lasting effects in terms of re-traumatization. We also know that young people that are admitted to secure care are often then admitted to other secure facilities such as youth justice. So in terms of the research and how we should be designing secure care, generally the literature indicates that it should be for a maximum of 2 to 3 children and for the shortest period of time. So that is pointing towards more of a crisis intervention model, which is then has a community-based longer-term therapeutic intervention alongside. And we also see evidence that it's effective, potentially if it's staffed by a mental health staffing model, and that we have staff education and trauma informed interventions that are really that are crucial to reducing incidents of restrictive measures. So I should also mention that the research is implying that which is supporting what we have known, I guess, in the sector for some time, that you need that multifaceted approach to secure care. So in multi-sectoral, we need the social care sector and the mental health sector and education, and I would extend that to the disability sector. And what I'm seeing internationally also is when we are having good practice, not only in secure care, but with alternative secure care, there's generally a commitment across sectors, but also across government. So from council, local to federal or national, whatever country you're in. So we have this multifaceted and collegial agreed on response to how secure care should function and what the alternatives should be. There's also research which really is suggesting the need for relational security to reduce restrictive practices within the secure care space. And I would go further than supporting the rigorous framework, but also to suggest there should be things such as mandatory minimum qualifications. So the intent of secure care has been some really interesting research recently about how secure care can also often trip itself over before it gets out of the finish line because it's very unclear what the intent is of secure care. And this is in terms of how we measure outcomes, but also young people's experience of secure care. So this article by Carolyn Endow was titled, "Am I supposed to be in a prison or a mental hospital?" Young people are very sort of confused about what the intent and the outcomes are associated with their intervention. And it really questions if we can't kind of really sort of nail what the intent is of our secure care intervention. How can we measure its outcomes, as I've sort of implied, but also how can we create that really sort of like targeted therapeutic context? So the research, I think this is, we can again spend a whole other presentation on this, but it relates to how we are conceptualizing children and young people. And there are two lines of thought in terms of the research, that children and young people admitted to secure care are the same as the offending cohort. The welfare and the offending cohort have exactly the same profile, and that we should be focusing on the needs, not the deeds. And then there's another line of thought that the two groups are quite distinct. They have very distinct needs and they pose a risk to one another, and not just in terms of the offending cohort to the welfare cohort, as we've potentially seen and was rationale for, again, our bifurcated system traditionally. But we also, there's research to suggest that it's actually this self-harming cohort that is traumatizing the offending cohort that don't have those same mental health needs as our welfare cohort. So this is my favorite quote in relation to secure care, this first one up online, that secure care is a temporary suspension of risk with questionable outcomes. It might be an intervention that we need. We might need that suspension of risk, but we have to acknowledge that there are questionable outcomes associated with the intervention and really work at minimizing them and focusing on alternatives. So I'll give you some, I guess, good practices regarding that in terms of what's happening internationally. So this is really the fundamental challenge for the sector at the moment is, and society as a whole, is how can we provide young people this kind of structure, safety and quality of care in the community without depriving them of their liberty, and also provide that multi-agency coordinated approach that I've referred to. So the standards and principles that are in place in relation to secure care, I'll just talk about this very quickly. So we have the UN OPCAT, Optional Protocol for the Convention Against Torture and Inhumane Treatment, and the UNCRC. The UNCRC really it captures the tension that we see in terms of our jurisdictions' need to protect children and young people. The states and territories have an obligation to make sure that young people are protected, but also that any form of detention is used as a measure of last resort and for the shortest period of time. But we also have some obligations regarding to providing legal access, prompt legal access, and the ability to appeal an admission through the court of law, which is not evident in all states and territories at the moment with secure care. So in terms of design, what does this look like? The research definitely suggests should be an option of last resort, so really nested in that context of alternatives in terms of both diversions and transitional support. It should be the shortest period of time, which supports that crisis style intervention, but also having that continuity of care. It should be transparent, so having really clear regulatory reports and oversight, making sure admissions data is available and information about the intervention. What we are seeing with OPCAT overseas is that the national prevention mechanisms are really providing that next level of oversight and transparency that we're not seeing in Australia yet, but hopefully that will be along soon. And making sure that young people and children that are admitted to secure care are done through the judicial system, that we have secure care orders and therefore legal representation for young people deprived of their liberty in the secure care space. So alternatives to secure care can take many forms, and these are not limited. So we have different types of secure care that can be intensive case management, whether it be bolstering the existing case management support that a young person's receiving, or whether it's another layer that's a new case management team that is particularly have that expertise. Or we have multi-agency intensive support and intensive specialist support services and diversion or transitional supports. What I found overseas was that these alternatives were particularly effective if they were immediately available, that they were family-centred, and secure care interventions do seem to be evolving in this space a little bit more internationally than in Australia, in that we're still very much focused on the young person and their behaviours, whereas internationally, young person's families or carers and their context are generally taken on the journey a little bit more, and the interventions are more holistic. And they're also effective when there's the continuity of care, so it's a long-term intervention, and that can be up to potentially age 25. Some countries that are really, I guess, responding to the research that is available are Scotland and the Netherlands. And particularly, I'll talk about them a little bit more later, but also Sweden. So Scotland have embarked on a Reimagining Secure Care project. And the Netherlands are also going through a lot of reform in this space, which I'll speak to. So the good stuff, international precedent. So the Nordic countries are different for Australia in that they have the higher age of criminal responsibility, but more than that, so for example, I'll be talking about Finland and Iceland. Minimum age of criminal responsibility is 15 years of age, but it should be noted that it is on exception that children are admitted to the criminal justice system below the age of 18 or sometimes 21. So it really is a welfare-based intervention for children with both offending and non-offending complex behaviours. So as such, they utilise secure care quite a lot. So secure care is delivered by both government and non-government providers in Finland. Now, this is, I mentioned, I've got this photo of Tammy and also Pia Eriksson. So Tammy is in charge of secure care in Finland. She came across from the women's prison system. She did a lot of reform in that space. So government, and Pia is from the Finnish Institute of Health and Welfare. So I often see, and particularly this is the case in Finland and the Netherlands and Scotland as well, is that they have these academic affiliations. So there's quite a nice relationship between the Youth Institute in the Netherlands or the Finnish Institute of Health and Welfare with government, and really the institutions provide a really important role in best practice, so whether it be design or training for staff. So these on the facilities actually aren't secure care facilities, these are their residential care facilities, but this is their secure care. So it's on the same campus, but they mentioned that the residential care on site wasn't so much a feeder, but the government provided secure care in Finland just respond to the pointy end of the secure care cohort. So that sounds a little bit sort of strange, but as I mentioned, they have higher numbers of secure care. They also have restrictive practices within the residential care sector, the out-of-home care sector actually in Finland. So the government secure care actually sort of intended and designed to respond to the pointy end of the sector's response. But I'm referring to it as good practice because when people ask me, where was the best secure care facility, it's a hard one to answer because I think fundamentally I'd like to see no secure care facilities. But I think Finland is often the one I refer to because everyone aims to have home-like environments within secure care. And this is probably the best that I saw internationally, just in terms of it was a maximum 4-bed facility, gender neutral, quite a home-like environment. You have your telltale signs such as the goldfish staff room, so with the glass so they can see into the rest of the house. But there were no kind of heavy locked doors, but there were no heavy doors, but you'll see there's also no kind of barbed wire fencing or walls around the facility. Staff didn't have radios, actually had software, which meant they got messages through their mobile phones. So it felt like much more of a home-like environment than you'll normally see in a secure care facility. And obviously they had a sauna. It goes without saying. It's a Finnish right to have a sauna. So there were saunas at all secure care facilities. And then we have Iceland. So Iceland is a little bit different and good practice in terms of it not being, well, it is conventionally an end stop, so it is the last resort, but it's also used as a diagnostic function. So it's an emergency short-term intervention that has alongside it actually on site a voluntary short-term treatment. So it can be for up to 12 weeks where young people can get really intensive AOD support. They, like Finland and like many countries, feel like the mental health sector is where they have they struggle to get buy-in and input from the mental health sector, and do feel like they need that support. But so I'm not sure why they've focused on the AOD. I think there's a shortage of psychiatrists in Iceland. It's incredibly hard to get psychiatrists. So Hawaii, I'm referring to, it doesn't have secure care. So I am just referring to it as good practice because they're in the process of finalising their Kavaloa Youth and Family Wellness Centre, which was basically converting their correctional facility into community-based interventions on site. So they re-legislated the land, so 14 acres, and they have a whole lot of community-based interventions. So for targeting sexual exploitations, education partners, they have a residential care facility, they have cultural interventions, all on site. But I mentioned this one as well because they kind of thought, well, if we do need a locked facility intervention, they think they need that mental health, clinical, psychiatric sort of driven response. So owned by the mental health system. So that was what they were endeavouring towards in Hawaii. Canada, like Australia, have secure care facilities in some jurisdictions and not in others. For example, Alberta use quite a lot of secure care, but for example, British Columbia don't have secure care. Secure care in Alberta is broken down into actually 3 types of interventions. So if you have your general secure care intervention, then you have a specific intervention for sexual exploitation, PCCA, and then you have another intervention for particularly opioid abuse. So that is a common reason for admission to PCHAD, is what they call it in Alberta. I thought this was good practice in terms of, gender neutral, but also it was just a given in terms of legal rights were really at the forefront. So young people really had ready access to legal representation and the rights of appeals process. It was really embedded within their system and the legislation. And also, so that one there, that is a Hull Services secure care facility in Alberta. And then another large campus-based, again, organisation was Wood Homes in Alberta. I'm referring to them not because they utilised secure care, but they had what was probably considered a direct alternative to secure care that was proving very effective in reducing placement breakdown post their residential. It was a residential care intervention. And I should just repeat what Tom mentioned earlier. I'm going through these slides quite quickly, but I thought it was a good resource to have because it was being recorded, but also will be publicly available. It can be referred to. And there's some references at the back for anyone who's after additional information. So apologies if I am going through it quite fast. So the Netherlands. Netherlands are really interesting because they made a commitment to ending the use of secure care by 2030. So again, they had, like the Nordic countries, they quite heavily utilised secure care, but there was a lot of public backlash led by lived experiences. So young people came to the forefront. This is actually a rally of young people that were protesting against the use of secure care, and it really captured the public's attention, and there was a lot of backlash and a political reaction to end the use by 2030. So as I mentioned, you have the Youth Institute that are working alongside the government, and the University of Amsterdam, which are doing a lot of research on how they can design alternatives to secure care. How can they respond to this cohort? And so this is an example of a secure care facility that is actually quite a large secure care facility, but it's in the process of converting to an open facility. So it currently, well, when I went, this was about a couple of years ago. So they had a combination of open, so 2 9-bed facilities and 6 10-bed facilities that were locked. And they were the process of converting it to open, flexible care. So I think it was a transitional period of what's referred to as flexi care, where it's open but with the ability to lock. And it was evolving into an outreach inpatient support. I think this is also one that's really good to highlight how legislation can be used to respond cross-sectorally. So this was a facility that admitted children through 3 sectors, 3 legislative capabilities. So through the social care legislation, through the mental health sector, and also the disability sector legislation. And then we have Scotland. So Kibble is a provider of secure care in Scotland. They stand out because this is Dan Johnson on the left, with actually the Dutch people. So University of Amsterdam, Eva in the centre there, and the other 2 Dutch colleagues are from the Youth Institute. So Kibble, they were visiting Kibble as well, because Kibble are good practice in terms of having the specialist intervention services. So this is Dan leads quite a large clinical team that are actually on site where the secure care facility is. So their secure facility at the moment has 3 units of up to 6 children and young people. However, Kibble for some time have been looking at how they can transition young people from secure care more effectively, but also divert children from secure care admissions by providing what they often call in Scotland as close care. So again, that flexible potential ability to lock up, but just providing a more intensive residential care option. And they're in the process of designing an open residential care facility, which they're explicitly saying will be providing a service, which is the gap in the mental health system. So for children and young people that are not quite meeting that threshold, but need that really intensive mental health response that is not available to them in the mental health system. And reimagining secure care. So if I was going to steer anyone in the direction of how to design secure care going forward, it would be to this resource. So the Scots have commissioned, so the Scottish Government commissioned the Children and Young People Centre for Justice, which is affiliated with the University of Strathclyde, to really look at how they can, what does the research say, and it aligns with what I was saying today, and how that translates into a new model of care. So their model of care is not having secure intervention at the forefront. So having it really, as I said, nested within that community-based intervention, so flexible local supports with that continuity of support being at the forefront, having that multi-sectoral intervention, but then having secure care as a flexi care. So as I've referred to as a really sort of adaptive intervention, like an intensive residential care service that has the capacity to lock on a needs basis. So not a kind of you're in or you're out of a locked facility, which will require very sort of customed style intervention to be fit for purpose. And there is a note that's incredibly important about how conscious they are about not net widening in that context. So there are issues, for example, I refer to Finland and restrictive interventions occurring within the out-of-home care sector, which is incredibly problematic on a number of levels, but really enables a kind of a net widening that the Scots are aware of. So that is me. There's just some resources at the end for anyone who's interested. I'll stop sharing my screen. And I went 2 minutes over. I'm sorry, Tom.
Absolutely perfect. Thank you, Kate, again. And on behalf of everyone in the room, thank you for sharing your expertise and insights. You've given us a bit of a whirlwind tour of kind of the international landscape, looking across multiple jurisdictions with alternative and different ways of approaching it. And each one of those will be a depth of detail and opportunity for us to interrogate in terms of what's gone well, what are the unintended consequences, what can we learn, and what insights can we draw. But like all things, kind of when we consider in this space, the holistic and wrap-around approaches that we do to support children, young people, and families beyond and through the interventions that we have available as far as a continuum of care becomes critically important.